So the thing I like about speaking last is you have the advantage of listening to all the other speakers. And the thing I like about speaking last is I never know what I'm going to say until I say it. And so much of my reactions are going to be based off of the comments that the other people have made. First of all, let's talk about aging a little bit. And I'm going to use this slide to make most of the points of what I really want to talk about. But people who aren't old don't know what it's like being old. I mean, you have a vision of us, an image of us, and we do the best we can sometimes to live up to your image. But it's different. So you need to think about aging as a very different process than being old and taken care of in your home and everything else. I think that given a degree of freedom, most people over age 65 have a lot of life left for them. And so I'm 82 years old, and I'm very fortunate to be very active in what I'm doing. But I think, I'm trying to remember when, but maybe around 2010, I was diagnosed with diabetes, type 2. And the doctor was teaching me how to puncture my finger and looking for a medication for me. And I said, oh, wait a minute, I'm not ready for this. Let's see what I can do about this. And I weighed 195 pounds. I now weigh 165. I wasn't all that active. I was a professor sitting down talking a lot. Now I'm behaving very differently. But a complete change. And the first thing I did was to find out what I needed to do. Part of that was the right diet. Part of that was exercise. Part of that was understanding the foods that I'm doing. So I lost weight, and I Googled to find out what I could eat. And I didn't take a diabetic diet or anything else, because I hate on the airplane, if you tell them you're diabetic, you're going to get really worse food than you get otherwise. So I keep that a secret a little bit from that. But I lost the weight. I did the exercise, and my hemoglobin A1C went from 7.6 to 5.9. In fact, my doctor now yells at me because she said a person your age shouldn't be that low. And I said, how does my body know I'm that old? So I mean, those are the kinds of things that I'm really talking about. The second point that I want to make out of some of the comments, I don't care what you've got, what data you've got within your system. Doesn't mean anything to me, because first of all, I recognize the fact that I go to the system twice a year. I'm old enough now that I don't have an annual. I have a twice a year examination. You have data on me twice a year. So you do a series of tests and everything else, and I'm curious. I look at it, and I see whether I'm red or green or yellow on the data, and I quickly forget about it. So what I do now is I have an Apple Watch that tells me how many steps that I take, and my daughter-in-law, I just got an email from my granddaughter that says that your daughter-in-law says it's 11 o'clock at night. She's walking up and down the street trying to get 10,000 steps so she can beat me. So again, it's those kind of motivations. But I weigh every day. I take my blood pressure when I want to. I take my glucose again when I want to. But I'm using measurements to guide my behavior. And I'm interested in doing the things that keep me alive, thinking, working, and everything else. Now, part of the problem with getting old is people think you sit there and rock in a rocking chair or watch television. And what we need to do is to recognize that these people still have value to society. Instead of putting us out to pasture, what we really need to do is to be engaged. Now, that creates social issues because we don't want to compete with the people that are younger. And I mean, you've been there and done that, so you need to let somebody else step into that agenda. But there are other things that you can do, all the things that I wanted to do, but wasn't able to do because I didn't have time to do it. Almost everybody has a hobby. So we need to encourage them to do with the hobby itself. Now, I want to use this to talk a little bit about the healthcare system. The first thing is that looking at what I call benchtop research. Those were the people that lived in the catacombs of Duke, medical center, coming up for air every once in a while, but looked as strange as you would look if you lived in a dungeon, and never talked to anybody else. All of a sudden now, we're finding that there is some data, some genetic data that's very important to us, that may give us some indications of our risk factor and everything else. So all of a sudden, I'm interested in what comes out of here. Now, one of the things that's been published a number of times is something that starts here and ends up here takes 17 years. That's a long time to wait for a discovery to have reality. And so what we're trying to do now is to change that time frame so that things that are discovered here are almost immediately applied to health care. And so one of the things that the new society does, where we're headed for, is to try to make this happen very, very quickly. The second thing is the clinical research community. So having said that, by the way, is here I've got to worry about how to take genetic information and put that into the electronic health record, because the electronic health record is the place where the clinical people go look for data. And so it's a repository. It's the things I need to know about what I'm doing. And so that's part of what we're doing. But that's a bidirectional gap. They give me data coming from the genomic world, but they need to know what happens in the clinical world. So is it useful? Is it predictable? What do we do about it? And I need that feedback. So now I've got suddenly a bidirectional link that comes through here with the people in clinical research sitting in the middle of that. And the clinical research people used to think that these people don't collect data that has trust. They don't collect data that has accuracy. We have to do it ourselves. And so they go down and dig out pieces of paper. And clinical research was who had the most patience to dig through all the pieces of paper. And if you had 15 people in your research, you were doing pretty good. Now we're talking about doing clinical research on actually several million, 170 million patients are one of the groups that we do research on currently. So again, we've got all sorts of connectivity that's got to go back and forth between all of these. And then we come into public health. That used to be the place I had to go prove that I had shots and things of this nature, reporting respiratory diseases. But that role is changing as well. And the difference between public health and population health, in fact, I'd probably make this now a subset of population health, although very clearly there are different responsibilities that we have to do. So part of where we are now, the compasses of doing all of this, is these used to be totally silos. And now they're coming together with overlapping competencies, and people that used to not even know each other existed all of a sudden are having to work together and talk to each other. So that really is the society that we're dealing with now. And patients have a much, I'm really going backwards. Different thing. Now, I'm not going to spend much time on this, but simply mention that we have a number of activities that really deal with the patient. So much of what we're talking about here in the compasses have to do with these kinds of initiatives, including the big data, the new media, all of the different kinds of things that we're doing, mobile devices and everything else. All is what's driving what's happening right now in healthcare, and standards is a key part of that, and interoperability is one of those magic words. When I retire, if it happens, what I want to do is to plot my career in two ways, one of which I'm going to measure my career in terms of the bytes of data that I was able to accommodate. And the second thing that I'm going to do is to look at new words that come into my vocabulary. And it's really interesting, over the almost 50 years that I will have been a faculty member, to look at the words when they come in. Interoperability is one of those magic words because I have used it in titles of talks and papers 40 times. And I did that last year. So we really jump quickly onto words that we're using. And I always say, if we aren't successful, we just change a word, not fix the problem, and keep going with that. But that's sort of where we are with all of that. FHIR is the new promise, and it is the new HL7 standard, And Catherine sort of introduced to that, but it's got two things in it that I think are extremely important. First of all, you can do anything you want to do with fire. It really has the capability of being used any way you want to use it. Now, it's critical, given that kind of freedom, that we understand management of that is much more difficult than if there are a set of rules. And so how do I keep that controlled in such a way that it doesn't become chaotic in terms of the use of that? There are resources, and resources define the data elements that I need to exchange with other people. For example, the patient resource defines all of the characteristics that I need to do to identify a patient. Name, address, multiple addresses, telephone numbers, age, race, all of those kind of demographic statistics are part of the resource that's named patient. And there's one for physician, one for an encounter, one for diagnosis, one for observation. There are all of these resources. But the good news about fire is every time I send you something, I don't have to tell you everything about it. So you can take me and pretty much, I always say my favorite introduction is "Here, Ed." So it's getting close enough that that's all you really need to know about me when I start to make a talk. If I'm making it for the first time, you tell me a lot more. But most of the people know me. And so "Here's Ed" is the kind of thing we're talking about. And that's the freedom that we need to do for exchange of information. If you send me a book, I'll put it on the shelf and I want to read it. But if you send me half a page, I'll look at it now. And that's the kind of thing that we have to think about in which we're going. And fire lets us do that. And then profiles is the way that we package that. So I want to do something, and this is the pieces that of the standard that I need to make that happen. So it's given me a lot more control, a lot more specificity, and I'm able to constrain to just what I need. And that's the real value of fire, in my opinion. So exchanging the resources between systems. And again, if I know you, if you're a trusted colleague, I can send you one set of things that you are able to understand and interpret. But if I don't know you, and increasingly now, so if somebody from the U.S. comes to Europe and has an accent of some sort, and I need that information, then I need to know exactly what I need to know to solve that particular problem. So it's a difference that needs to change with what we're doing. So that's the piece that we're going now. She's getting ready to come up, so I'm going to do this. But so I finished with looking at the future, and the future really is exciting. It's an opportunity of changing, and that's where we're going.
Thank you.
So you can yank me off.
Yep.